I've got some slides coming up. So really good to be here with you today, and actually to be set up nicely by that last question, because I think you all know that structures are not magic wands. Just because you change the structure, it doesn't suddenly make integration happen. And what I want to talk to you about today is some of the experiences from the English, specifically English, system over the last few years that you might think about as you move into the new RHA structures here in Ireland. And I'm drawing from two pieces of work that we've done in the Nuffield Trust in recent years, particularly, as well as my own personal experience in developing integrated care. So Nigel and I did a piece of work, Nigel Edwards, our chief exec, just before the pandemic, looking at what lessons we could learn from the last iteration of the regional tiers in the NHS, because we had a sense that that would give us some pointers for the new integrated care systems that are being put in place. And then we've done a piece of work much more recently, we published it just 2 or 3 weeks ago, which is looking at what's actually happening now within integrated care systems. So I'm going to draw on both of those. And obviously this is coming from the English context, but I think it will resonate with you, not just because what you're putting in place now is actually very similar to the ICS structure, but actually because fundamentally it's about how people behave. And what it is that enables people to work in ways that we actually want them to do, and what might get in the way of that. So a quick history. People say that the only constant in the NHS is change. Actually, the NHS was pretty constant from its inception through to 1974, and then we've had quite a lot of change since. And Nigel has a couple of laws. He has a statement that says, in the event of a nuclear war, the only two things that will survive will be cockroaches and the regional tier of the NHS. And the second law is that no reorganisation of the NHS can result in a number of regional bodies that is the same as any previous iteration of the NHS, and you can see that we do tend to stick to that. But I think particularly to note is that from here to here, all those restructures were essentially restructures of the commissioning and the planning system. They didn't really touch what happened in providers. It's not that they didn't create issues for providers, because providers had to recreate their relationships every time. But it's this change, or one of the things that's different about this change that we're seeing now, which really ties providers into the system much more. And that's quite significant for them as well as the rest of the commissioning system. So, and our ICSs, I think, are pretty analogous to what you're putting in place with the regional health areas. So I'll run through some quick lessons from the past, from the time of SHAs, and then I'll go into what's happening now. So first lesson from the past, you need clarity of purpose. You need to understand what this organisation in the middle between what's happening in government and what's happening on the front line, what it's for. Is it a regulator? Is it a performance manager? Is it a planner? Is it all three of those things? Actually, at one level, it doesn't matter what it is. What matters is that the people who are in the system understand what it is. So you can design it in all sorts of different ways. What matters is that from top to bottom, everybody knows that the role of this organisation is to do X. I think the other thing that's interesting about middle tier organisations is that they tend to sit at the point where national priorities hit local priorities. And that creates some challenges as well. So one is that there's a risk of too many priorities. So you get, I don't know, your cancer plan, your mental health plan, and your diabetes plan, and your MSK plan, and everything else coming down from the centre. And at a local level, this hospital's falling down, and that community's got a real problem with mental health issues, and so on and so forth. And the task of the leader in the centre is to make sense of that. Is to help manage, and this means some managing up as well as managing down, help manage the number of priorities, but perhaps even more importantly, create a coherent narrative so that the people who are working in that system understand what's important here. And that links really to one of the next points. What's important here? Context matters. So you do need to understand the starting point. You need to understand that, is this an area where there is significant ill health which dates back from the closure of heavy industry, or is this an area where there's lots of poverty because it's a very deprived rural or coastal area, or is this a very affluent area where people are very demanding of services? Doesn't matter quite what the background is. It does matter that you understand what the background is, and that actually you understand some of the big and small P political history, and actually what's happened in the services in previous years, what the baggage that people are bringing with them, as well as what the aspirations that people have are for the future. Size matters. Our ICS is very, very heterogeneous. Our biggest ICS in the northeast of England covers a population of 3 million people, and I don't know how many square miles, but lots. Our smallest ICS, just outside London, is a population of a bit over 500,000 people. They'll both work. They'll both be fine because they're designed for what works for their area. But it does mean that they will work differently. And Nigel and I have started talking about thick ICSs and thin ICSs. If you're in an area which is big, is covering a wide geography, is perhaps covering a lot of local authorities, probably what you do at the ICS level will be quite high level. The action will be much more in the place. If you're in a small ICS, you're pretty coterminous with the place. So again, things will happen differently because they need to happen differently because of the way that you're designed. And personalities matter. And I will come back to this a bit later on as well. But one of the very early leadership lessons for me was actually when I did, oh goodness, how long ago? Probably about 25 years ago. I came out to Northern Ireland because at that point, Northern Ireland was ahead of the rest of the UK in terms of its working together of health and social care. And I wanted to learn from that. And I had a lovely week going around lots of different organisations. And there were two that stuck in my mind. They were both providers of community primary care and social care services. And one had really good integration between its community and primary care, but social care was kind of over here. And the other had really good integration between community and social care, but primary care was kind of over here. And what I realised was actually, because that's where the interests of the chief exec lay. So theoretically, they were all doing the same things, but what was happening in those organisations was what the chief exec thought was important. And that taught me a real lesson about leadership and just thinking about understanding my priorities, but actually also understanding how individual leaders' priorities can affect what an organisation does. So personalities do matter, even if you think they shouldn't. Relationships. It's all about relationships. And if you're in a middle tier organisation, you have relationships everywhere. So you have relationships up. So as Yvonne said, the chief execs of the RHAs will report directly to the chief exec of the HSE, which means they're going to have a close relationship with government as well, for good or bad. But they will also need to have relationships down with the providers in their local systems. They'll need to have relationships out with their local authorities and perhaps their VCSE organisations as well. And they'll need to think about actually how they manage all those different relationships and what their role is. Very often the role of the regional team in managing the relationships is about being the buffer or holding the umbrella up. So actually being able to reassure the centre that actually we know what we're doing, things are okay, and being able to some degree protect the people beneath them from the multiplicity of demands that are falling on them. And going back to my point about clarity of purpose, being able to say actually, we know we can see all these papers coming out the HSE or in the newspapers or whatever. The things that matter here are A, B, and C, and we know that those are the things that matter here because. So there's a real role there about sense making and buffering. Now I said I'd come back to personalities. One of the things that was really interesting when we did our work on SHAs was talking to people about this point and not only the role of SHAs but actually how they did it. And it was really interesting when we talked to people about bullying because everybody knew that there were times in the histories of the SHAs and their predecessors that bullying happened. And nobody wanted to talk about it. They would talk about it when we did individual interviews, but when we got people around tables, they would not talk about it. There's something that's really important, I think, for people to watch when you're thinking about the role of a middle-tier organisation in managing change and improvement, that they do it in a way which manages people effectively, because the behaviours that people see at the top ripple down through an organisation. And so when we looked at the different SHAs, the personality of the leaders of the SHAs rippled out through the different layers of those organisations. And that has consequences that continue, because actually most of us have long careers in the service and we move around. And so the people, quite a significant proportion of the people working in the middle tier of the NHS now were working in the middle tier in the SHAs at times when, frankly, bullying behaviour was going on. and you can still see it coming through now. So it's actually just watching those behaviours can be really important. Works the other way as well. People have really good role models and they hang on to those for the rest of their careers too, but the bullying can perhaps have a bigger impact than you expect. She made that point about looking beyond the health bubble as well, and that's particularly important when we're thinking about improving health and not just fixing health care. And one of the things that we found was interesting actually was that our SHAs didn't have as strong relationships as we might have expected with organisations like local authorities, the VCSE, perhaps the universities. They varied a bit. That's something that we think actually ICSs will do differently. We think they will have much stronger external relationships. Sources of power. Now, it's interesting because you can draw a nice organogram and you can see the lines of accountability and you think, okay, here are the levers, this is where I can pull levers. What we found, and I don't think this is entirely surprising, was that actually the soft power that SHAs exercised mostly was much more significant than they using the hard levers. Yeah, people could pull on those levers when they needed to, but actually they got stuff done, and leaders in SHAs got stuff done through the relationships they had with local leaders as well as their relationships up. There was an interesting point about the role of boards, and I don't think the RHAs are going to have their own boards. No, they're not. SHAs did. And one of the things that did mean in some places was that SHAs were able to be perhaps a little bit more independent than the regional teams in NHS England that succeeded them. They were able to say, actually, no, this is what matters here, and this is what we are going to prioritise, and this is why, and kind of give a bit of strength to their chief exec in that conversation. So, you won't have boards. So, that underlines the importance, I think, of really making sure that the people who are leading the RHAs are able to do that negotiation and narrative that connects your national priorities and your local priorities and help people understand that what they're going to focus on here. And really interesting role again for the SHAs was about talent management. And this is interesting in looking over time about is the role of the regional leader the absolute pinnacle of your career, or is it your career graveyard? And we see that differently at different times in the NHS. So if I go back to when I started, which is 30 years ago, the people who were leading the regional offices then were absolutely the big people, the people who had grown up through the system, and they were the most senior leaders and the most respected leaders. We then went through quite a phase where actually, if you were going to have a really big career in the NHS, your success was measured by the size of the hospital you ran. I think we are actually now moving back to a place where it is the key leadership roles are those that are seen as the system roles. But it matters because actually we want the right people and we want good people everywhere. But you really need people to, if you're going to make the RHAs a success, that needs to be a place where people say, actually, this is going to be a really good place to develop and grow my career. So thinking about talent management and thinking about how you get the right leaders, both clinical and non-clinical in there, really important thing to do. So that was a quick canter through the past and what it tells us of the future. So what's actually happening now? As I say, we spent some time looking at what's happening within ICSs, within places. So this is where we're bringing hospitals, community services, primary care, VCSE, social care together, and actually knitting them together into the governance structure in a way that hasn't happened in the past. And I think I've seen more progress on integration and collaboration in the last 3 years than I have in the last 30. And lots of reasons for that. The pandemic actually did help. I think we've also got a cohort of leaders who are increasingly getting here as well as here that their job is to run their organisation and that their organisation is part of a system. It's not that the organisation is above all and the system's over there somewhere, that the two come together. So I think we're definitely making progress, but there's still a way to go. And one of the things that we observe, and I'd be amazed if it's different here, I think I heard some people talking to this before, is that we've talked a rhetoric of being person-centred and we've talked a rhetoric about investing in the community and all those things all my career, 30 years. We are still hospital-centric. And we are still, that's where our resources go, that's where we measure performance, that's where we talk about it. And to some extent it's understandable, because if you're outside the service, you can recognise a hospital, you can touch it, you think you know what goes on in there. Much harder to do that for services that run outside hospitals. But if we're serious about what we want to do around population health and about shifting that balance, then our community and primary care organisations are probably our most strategically important organisations. And we've got a long way to go to shift the culture and the power dynamics to make that real. Complexity is a reality of life. It's not going to go away. We do not, as individuals, live our lives in neat little boxes. Our health services are not organised in neat little boxes. There will be flows across boundaries of your RHAs. That's life. So one of the challenges for local leaders is how you make sense of that complexity. Resource constraints are not going to go away. We do not have enough money in our service, and that manifests through our workforce, it manifests through our capital investment, manifests through our IT. But not only do we not have enough money in total, we don't have the money that we do have in the right places, or the resources that we do have in the right places. And again, our resource pattern, if you like, is very hospital-centric at the moment. So one of the things we need to think about is how we shift that. Measuring integration. I'm going to come on to that in a little bit more detail, but there are something like 170 different definitions of integration. So what do we mean? That's a real challenge for a lot of people. And the last point, the integration fatigue. So not only do we have a workforce that's pretty knackered after the last 3 years of the pandemic and the very difficult winter that we've had as well as you've had here, we have staff we've talked the talk about integration for an awfully long time, and they're all going, really? Another time? What's going to happen differently this time? So there's a real kind of inspiration challenge. So what do we do? It's got to be part of the day job. Nigel and I talk about the Monday morning question. What will be different on a Monday morning as a result of whatever we're doing here? And that plays out at every level. What will be different for the chief exec? What conversations will the chief exec be having that are different, and who will they be having those conversations with? Just as much as what will be different for the GP or what will be different for the district nurse. So really, for local leaders and indeed national leaders to be thinking, to put a kind of integration in all policies mindset on, and think about, whatever we are talking about here, what does that mean for the different parts of the system? What actually needs to happen differently? And to recognise, and as I'm sure Yvonne does, that actually this change is not a big bang overnight change, it's a series of incremental steps, and they will accumulate over time to create a different impact for both patients and the workforce. And it requires, and it was good to hear Yvonne say that the RHAs will have the autonomy. It does require some devolution of power, which can be difficult for politicians. Clarity to complexity, as I said, organisations, hospitals, community services do not sit in a little bubble. They will have all sorts of different networks which are real and are not going to change and shouldn't change because they're there for good reasons. But your challenge then as a leader is to be able to say, in this area, this is what our system looks like. This is how our lines of accountability work. This is where our patients come to and from. And to keep watching over time, to be a learning system, to make sure that you continue to get that right. Because complexity is a reality, and part of the reality of complexity is that things change. So you do need to keep watching that over time. Now, I said I'd come back to performance management and metrics. What are we actually here for? What are we trying to achieve through integration? This logic model is a kind of buzzword of the last couple of years, but actually there's something really important about an organisation being able to say, this is what we want to be able to achieve, and these are the steps that we're going to take to achieve it, and this is why we think it'll work, and this is how we're going to measure it. There's something about making sure that you've got measures over the long term as well as the short term. There will be some things that you'll do quickly. Actually, a lot of what you want to achieve won't show up for another 10 or 20 years, and that's okay, but you need to be able to watch out for that. I think people need to be able to think about qualitative as well as quantitative measures. So this is not just about the numbers. The numbers are important, but a lot of what we want to measure in terms of integration is what people, patients and staff actually experience, and that doesn't always show itself up in numbers. And what's your counterfactual? I think it was really interesting in that panel session earlier on when the first speaker said, well, we haven't seen a difference in hospitals. So I thought, you might have done. You may still be seeing more people going in, but actually, if things hadn't happened, would you be seeing more people going in? So, success isn't always measured against the here and now. Success may be measured against a counterfactual. So, do you need to really think carefully about your measures on that? I've touched on capacity already and said we've got our resources in the wrong places. I think one of the really interesting things is we've got our change management capacity in the wrong places. We want to see change outside the hospital for all good reasons, but actually all our management capacity and our change management capacity sits in the hospital. So one of the things that ICS's places can do is not only say we want to redesign services so that we move the service capacity, they can also say in order to do that, we're going to need to share our management capacity and use our management capacity and our change management capacity differently. My final slide, culture eats strategy for breakfast. If culture is the way we do things around here, the only way we change the culture is by changing what we do around here. So we need to understand each other's cultures. We need to understand what lies behind them. You know, if you're working with different organisations, particularly outside the health system, understand their constraints, understand what they can and can't do, walk in each other's shoes, but then start saying, okay, what are we going to do? What are we going to do differently? And I don't quite mean a little less conversation, because actually talking is a really important part of shifting culture, but those conversations should always lead to action. So that's a very quick canter through, and could talk at much greater length about what's been happening in the English NHS over the last few years and where we think it might, what the issues are we think for the future, which I hope does resonate for you. And have we got time for a couple of questions?
We haven't, but we will anyway, because it was so interesting, Helen. And,
Destroy the slides.
I mean, there was nothing there I don't think that anyone's going to disagree with. It all makes perfect sense, and it's a really useful perspective that you've given us. So, question here. Yes, lady with the microphone.
Similar to the last question, how does the whole digital strategy fit into this? Because we had the NHS Digital, NHSX, then we still have different hospitals and groups selecting different platforms and so on. So how does this all fit in?
I think it's it's a really important question, and frankly not entirely clear at the moment, because NHSX and NHS Digital have now just got wrapped up into NHS England, which is right, because it means that actually what we're doing is bringing everything together. I think it does play out at different levels. So some of it's about, as Yvonne was talking about earlier, as well as other people on the panel, how you use your data differently and how you collect your data differently, and some of it's about how you use your technology differently. So there is, NHS England will be ensuring that there is a national digital strategy. Every ICS will be expected to have a digital strategy, but it kind of goes back to my point at the beginning about starting points are different. So I think I expect over 5 years-ish, a time frame, that we will see broadly similar shifts in the way, if we compare ourselves then and now, that actually we will see everywhere that people are using technology better and differently, and that individual patients and the public are using them differently as well. I think the pandemic's been interesting for that, because it's enabled the people who are in receipt of services to think differently about the use of technology. But it's not going to be a one-size-fits-all approach to get there.
One more quick question before we move on. Yes, maybe it's great.
Sorry, just a question. Have you experienced maybe where you've segregated it out into the regional areas like we're planning in Ireland, where there may be stronger negotiators in some regionals, particularly with the vendors, and they're benefiting more and accelerating further? And have you any strategies for managing that?
Yeah, I think that's where the relationship between the region and the centre becomes really important, because if you give regions too much autonomy, I don't know too much autonomy is a thing. People have different strengths, and actually I think there is a real value in being able to draw on the strength of a central negotiation to get that right. Having said that, it's really important the centre understands the needs of local areas. So I remember, 3 or 4 iterations of our digital strategy ago. National Programme for IT. First conversation I had, I was working as a local leader then, with somebody from the National Programme for IT, was how is this going to help me get health and social care data together? And said, it's not commissioned to cover social care. So it is important that people at centre actually understand what's needed at the ground.
Brilliant. Brilliant. Listen, will you join me in thanking Helen once again? Thank you very much.